Good evening, everybody, and welcome to the last installment in this series. And it is often a cliche, but last and definitely not least. Tonight we have the educator extraordinaire, Dr. Sherry Schaefer. She studied nutrition at the University of Berkeley and then joined UCSF to teach anybody pretty much on campus about diabetes. So she's teaching medical students, pharmacy students, PT students, residents, and is also actively involved in educating patients, both pediatric patients as well as adults. So anybody who ever needs to learn anything about diabetes needs to speak to Dr. Schaefer. As always, I'd like to finish the introduction by reading what the students wrote about her when she lectured for the medical students last year. So I really don't want to take up any more time, so let me just read to you what the students' student comments were after they had received the lecture from Dr. Schaefer. So wonderful, really clear scientific and clinical points, and it is very obvious she is a wonderful healthcare provider. Other students wrote, a great instructor, exclamation point, and wonderful lectures. So really, please join me in welcoming Dr. Sherry Schaefer.
So I hope to talk a little bit about type 1, type 2, a little bit about kids and adults, some of the new things on the horizon, and we'll go ahead and get started with just defining what diabetes is. Diabetes is really a group of diseases that are characterized by high blood sugar, and that can happen for several reasons, but the two most common are defects in insulin secretion, that's when the pancreas no longer makes insulin appropriately, or defects in insulin action, where a person makes insulin that doesn't function very well. It'd be like a key that doesn't quite open the door, would be a way of looking at that. And some people have both defects. So early on with type 2 diabetes, it might just be that the insulin doesn't work very well, but 20 years into it, it might be a combination of that person not making as much insulin as well. So type 1 diabetes is only 5 to 10% of all cases, but it seems to be well known, if you know anyone that's had type 1 diabetes, how difficult it can be to control, and things have certainly gotten better over the last decade or two, but it can happen anytime. They used to call it insulin-dependent diabetes, they used to call it juvenile diabetes, and it can happen when you're 50 years old. I had adults in my clinic that got diagnosed with true type 1 diabetes in their 40s or 50s. So along with the fact that many type 2s use insulin as well, they changed the terminology and now it's referred to as type 1 diabetes and type 2 diabetes. People with type 1 diabetes will require insulin injections their entire life. Prior to 1920, when insulin was first used in the lab and produced, people didn't survive if they were diagnosed with type 1 diabetes. For type 2 diabetes, that's much more common. That's 90% of all cases. And in fact, there are still estimated to be about 1/3 of the people in our country that have it who don't know they have it yet. So they're walking around with high blood sugars, and oftentimes they've had it 5, 7, or 10 years prior to getting their diagnosis. They go in with a complication, complaining of their feet or their eyes, and they find out that they've had high blood sugar. So it doesn't necessarily hurt, and that's why people need to be screened to become aware of who's at risk. The majority of individuals that get type 2 diabetes are overweight, but some people are completely thin. Oftentimes Asians get type 2 diabetes at a more normal body weight. And although type 2 diabetes used to be considered adult onset diabetes, in my pediatric diabetes clinic we have about 500 kids and about 1 in 3 are type 2 these days. Unfortunately, type 2 diabetes often occurs with other problems, and heart, cholesterol, hypertension are among them. And it's estimated that 65% of people who have type 2 diabetes, eventually it's heart disease that they die from. So we have to look at the lipids as well, and we're going to talk about that nutritionally tonight. So gestational diabetes is when diabetes is first discovered during pregnancy. And it's usually discovered in the latter part of pregnancy. That's when it's screened for. It's about 7% actually of people that get gestational diabetes, and it's the insulin resistance caused by their pregnancy hormones. So when the hormones from the placenta put out a lot of resistance to the insulin, the blood sugars start to rise. You screen for it between 24 and 28 weeks. But if you have a woman who comes in pregnant and she's 12 weeks or 8 weeks pregnant, you think this woman could have type 2 and not know it, you would screen her right away at her first visit. You might discover that she's had type 2. And sadly, about 50% of all women who get gestational diabetes end up getting type 2 diabetes 5, 10, 15 years down the road. The risk factors are similar. So if you have someone with gestational diabetes who's showing you that they don't handle stress of some sort, pregnancy being the stress hormones that they're not handling, when that person ages, that might be enough to push them into type 2 diabetes, or if they put weight on. The risk factors, as I said, for type 2 and gestational are the same. If you have a family history, that's a very strong risk factor. If you're overweight, that's a reason to be screened. If you're a certain ethnic group, the risk of having type 2 diabetes goes up. That's African American, Hispanic American, Native American, it's Asian American and Pacific Islanders, whereas type 1 is more Northern European. That's the risk factor, the genetics there. The cardiac risk factors, if you have somebody that has high cholesterol, hypertension, high triglycerides, low HDL, that's the kind of person you should screen for type 2 diabetes. They kind of occur together oftentimes. Polycystic ovarian syndrome is a grouping of syndromes, but insulin resistance is part of that. So a lot of these women end up with type 2 diabetes. And then if you ever see anybody that has the dark band of skin around the back of the neck, that's an indication of insulin resistance. It's called acanthosis nigricans. And in the community, in the store, on the bus, you might see somebody with this dark band of skin, and you want to say something to them, like, have you been screened? But I have to stop myself. It's not the right place. Looking at the trends, if we go to 1990 and you look at this slide, the light blue means that state has less than 4% of its population with type 2 diabetes. The next color is 4 to 6, the darker color is 6 to 8, and you can see 17 years ago, it was already quite concerning. If you jump ahead 5 years to 1995, darkens up a lot. Now you're seeing a good majority of the states with 4 to 6% of their population with type 2 diabetes, even 6 to 8% in many states. Jump ahead to 2001, and I would say the majority of states have at least the 6 to 8%, and now you're seeing the pink states representing 8 to 10% of their population, and red states, 1 in 10 people have type 2 diabetes. And this goes back to 2001. And now we're at 2007. I can guarantee this has changed a lot. It's just not in a slide for me. And the only time I want to see that many blue states, if I'm allowed to say it, is November of 2008. Diagnosing diabetes, fasting blood sugar is the standard way to check somebody. And normal blood sugar fasting should be under 100. And pre-diabetes is not quite diabetes, but it's a person who's tending in that direction. Diabetes is diagnosed as 126 or higher fasting. Some people walk into the clinic, they're not fasting, they're not going to be back for a while. You can check them after a meal. And if they're above 200, they're very likely someone with diabetes. But they should go back for a fasting screen as well. So pre-diabetes is kind of a new term. They used to call it impaired fasting glucose or impaired glucose tolerance, but that didn't get the public's attention, so they changed it to include the word diabetes because it's estimated, and I change the slide every year, current estimation is 54 million Americans have pre-diabetes, and it's expected that most will end up getting type 2 diabetes. The prevention strategies are to screen those people who we know are at risk by looking at those risk factors I listed. And then, since the majority of people with type 2 diabetes are overweight, it should always be a consideration to control weight and to include exercise, because exercise helps prevent type 2 diabetes. They did a study called the Diabetes Prevention Program, and they studied 3,234 patients that had prediabetes. They were in that range of not normal, not quite diabetic, and they studied them for 3 years, separating them into 3 groups. The first group got no intervention. The second group got lots of education, lots of dietitian time, learning diet tips, exercise tips, behavior modification. And the third arm of the study took a medication called metformin, also called glucophage. And the people that had the lifestyle intervention had a 58% reduction of progressing on to get type 2 diabetes, whereas the medicated group was 31% reduction in incidence of type 2. So clearly, lifestyle modifications are very effective in preventing type 2 diabetes or delaying it. As I said, kids get type 2, and I want people to be aware, if you have type 2, if there's type 2 in your family and you have a chubby kid, that child should be checked. We don't want it to go unnoticed. We don't want kids to have that many extra years of risk factors because they had uncontrolled blood sugar. And if you look at, like I said, the children that, or the adolescents with diabetes, it's about 1 in 3 now that have type 2. And if you went back 50 or 60 years, it would be an anomaly to see a child with type 2 diabetes. The obesity in youth is contributing to this. If we screen all the obese children and adolescents, we're finding almost 1 in 4 already have pre-diabetes at those young ages. So screen children who are overweight and who are over 10 years old. Generally, you don't see children that are 6 or 8 getting type 2 diabetes. There's the puberty hormones that also kick into insulin resistance that play into this. But children that have 2 of these risk factors are at very high risk, and they should be screened every 2 years. In terms of women who already have diabetes, type 1 or type 2, and they want to plan a family, they should have preconception counseling because there are considerable risks to having high blood sugar while you're pregnant. So preconception counseling should include discussing the complications that are a potential, and also that the mother, if she has any problems with her eyes or kidneys already, the pregnancy can put undue stress on those organs. So we want women already checking their blood sugar routinely and taking care of their diets and keeping records and not getting pregnant until their blood sugar control tells them it's safe. And we'll talk about the A1C test a little later, but the hemoglobin A1C of less than 7 is considered target for people with diabetes. So just briefly, the risk factors, if you do have diabetes and you're not controlling your blood sugar, the big ones are miscarriage in the first trimester, and in the first trimester also birth defects. Because during the first 12 weeks, the fetus is forming, the spine is closing, the brain is forming, and if the blood sugar is high, the spine might not close, the brain might not develop. You see heart defects, primarily chamber holes between the different chambers, kidney defects, or even babies that are born with the organs on the complete opposite sides of the body. Back in the 60s, 1 in 4 pregnancies miscarried. It's come down a lot because of the tools that we have in controlling diabetes. In the second and third trimester, if the blood sugar is high, the baby's sucking it up, getting lots of sugar, getting bigger and bigger and bigger, and you have a risk of macrosomia, which is a baby that weighs over 9 pounds. Those babies are hard to deliver. You could have a dislocated shoulder or a broken clavicle, or there might be stillbirth is the worst case scenario. The blood sugar is poorly controlled. Women might have stillbirth in their last couple weeks of pregnancy. The symptoms of high blood sugar, sometime you're walking around with diabetes type 2 and there are no symptoms. That's why you have to be screened. But very high blood sugar can lead to increased urination. When the blood sugar is about 180 or higher, the kidneys try to get rid of glucose, so you go to the bathroom more. If you're going to the bathroom more, presumably you're more thirsty. So you might feel thirsty, and that would be an indicator. You might feel hungry because if you're urinating out glucose and calories, you're not feeding your body with that fuel, and it might trigger hunger. You might have weight loss because of that, loss of calories. You might have blurred vision, not as a long-term complication, but rather when the blood sugar is high, it's absorbed into the lens of the eye, which then swells, and then the image is distorted because of the swollen lens. A lot of people go in and get their eyes checked, they have blurry vision, they get new glasses, they find out they have diabetes, their blood sugar gets controlled, the glasses don't work anymore. So check your blood sugar first. yeast and fungal infections, because those kinds of things love sweet tissue to live in, and fatigue can be a risk factor, or a symptom, I'm sorry. The short-term complications that we are concerned about are different, whether you're in type 1 diabetes or type 2. Type 1 is diabetic ketoacidosis, and if there's not insulin available, the body can't metabolize its fuel correctly. The blood sugars rise, and you start to burn fat in an abnormal manner, which produces something called ketones. My next slides will show you what that is. For type 2, hyperglycemic hyperosmolar non-ketotic syndrome. The blood sugars can go to 800, 900, 1,000. They don't get ketones. Ketones cause acidosis. Ketones are a low pH, and if your levels of ketones are rising, as in lack of insulin, type 1 diabetes, that's rapid. You end up very sick very fast. It can be life-threatening. Hyperosmolar can go on for a long time with the blood sugars being high, but you can go into a coma because of that. Ketones, as I said, okay, so what happens is if you don't have insulin available, you can't use glucose. Your body's forced to use an alternate fuel source, and the liver cells can use fat and convert that into something called ketones. Now, the brain and the heart and vital organs can use ketones as a fuel source, but unfortunately, the pH drops. So as those levels rise, the pH drops further. A cell with adequate insulin will allow glucose and fatty acids to enter the cell to be metabolized. And as you know, you burn anything, there's always a byproduct. So the byproduct of metabolism would be carbon dioxide, which you breathe out, and water. That's normal fuel metabolism and byproducts. But if you have type 1 diabetes, or your insulin went bad, you left it in the car and it got too hot, for some reason your insulin's not working, you take insulin out of the picture, glucose cannot get into the cell. You're not going to burn glucose, but your body will alternatively send fats to the liver cells. The liver cells will take those fats and metabolize them into ketones. And your body can stay alive for a while burning ketones, but not for a whole long time. So we want to be careful about insulin omission. Often happens with my teenagers. They get tired of having diabetes, they decide not to take insulin for a few days, and we see them in the emergency room. You can't not take insulin. So the long-term complications are similar, whether it's type 1 or type 2. It's not what type of diabetes, it's the level of poor control that you look at. So whether it's type 1 or type 2, if the blood sugars are high, anybody can get any complication. The things we look out for are blood vessel disease, the large vessels leading to heart disease, stroke, peripheral vascular disease in the legs. The small vessels in the eyes and the kidneys can become damaged. The nerves can become damaged. And if those nerves happen in your feet and hands, it's tingling and pain or loss of sensation, which is a problem if you step on something and you don't realize you stepped on it. My aunt, very poorly controlled diabetes, stepped on a sewing needle, didn't know it for 3 weeks until her foot was this big and red, and they x-rayed it and saw a needle sticking straight in it. She felt nothing. And so if you have no sensation, and then you have high sugar, the bacteria love it, and then the infection grows, and you might end up with an amputation because it doesn't heal well. Your antibodies, your immune system doesn't work as well when your blood sugars are high. So you put all those things together, and that's where the amputations can happen. All of these things are preventable. What happens when the blood sugar is high is it sets up camp. It's going to burrow into blood vessels, and it's going to set roots, and it's going to attach, and that's called glycosylation. So instead of the blood sugar just going through the blood vessels and being energy for the muscles and cells, it actually is the level's too high, and so some of it starts to embed. And that's called glycosylation, and if that happens year after year after year in tiny little blood vessels, it damages those blood vessels in the eyes and kidneys, and that's what causes the complication. So back to the hemoglobin A1C test. This is a test that measures the glycosylation of the hemoglobin in the blood cell. So it's a part of the blood cell. Now, we can't dig around in someone's eyes and look at how much sugar is attached to those small blood vessels, and we can't dig around in their kidneys without damaging things. So what we can look at easily is a drop of blood. We can take blood, we can look at it, we can see how much sugar is attached to the blood. Not a big deal because you're going to make new blood all the time. And on average, your blood volume is turned over every 3 months or so. So if we look at what the glycosylation is of the blood, we can tell what the control of that person's blood sugar has been for the last 3-month period. And a hemoglobin A1C of 5 means the average blood sugar has been about 100, which is the numbers you're used to seeing on a meter. 6 is 135. In fact, for every point you go up, it adds another 35. So you can kind of commit it to memory if you know 5 is 100. And the goal for diabetes is 7 or less, under 7. And if you can achieve under 6 without becoming dangerously hypoglycemic, then that can be a goal for some people. So they wanted to study, are these complications preventable? Can we reduce them? And they did a group called the Diabetes Control and Complications Trial. They studied 1,442 people for 10 years. They had 2 study arms. One got lots of education. They took at least 3 shots a day. They adjusted their insulin. If they were going to eat more, they took more insulin. If they were going to exercise, they took less. They checked their blood sugar frequently. And all those things allowed them to achieve better control. That's the intensive therapy group. The conventional therapy group got very little education. They took no more than 2 shots a day. And at the end of the study, the hemoglobin A1C of the intensively managed was about 7%, which is about our target that we have set. And the conventional therapy group was about 9. So what did that mean? They looked at the complications in these people, and they found that by intensive management, there was 76% less eye damage, 54% less kidney damage, and 60% less nerve damage at the end of the study for the intensively managed group. So then, of course, the question was, is that going to hold true for type 2 diabetes? And that spawned another study called the United Kingdom Prospective Diabetes Study. It studied 5,102 people with newly diagnosed type 2 for 10 years also. And they wanted to look at not only blood sugar control, but also blood pressure control. For each point reduction in A1C, there was about 35% less complications overall and 25% less diabetes-related deaths, less heart attack. But not only that, the blood pressure made a huge difference. The target for blood pressure for diabetes is 130/80. They didn't even achieve that. Despite not achieving target, they had huge reductions in many complications, including large vessel disease, 44% less stroke, and small vessel disease as well, with the microvascular being small vessel disease. So it's pretty clear that if we can control diabetes blood sugars, we can prevent complications. But it's going to take a lot of pieces of the puzzle fitting together. It's not just one thing. We need to look at medication, food, exercise, and blood glucose results. The medications, when you're talking about type 1 diabetes, it's insulin, okay? And up to 40% of type 2s will also use insulin to achieve the targets that they're looking for. And if you have gestational diabetes and you require help, it's going to be insulin because oral agents generally are contraindicated, not recommended. So insulin is a hormone, which means it's a protein, which means you can't eat it. It has to be injected. And I know if you want to ask a question later about inhaled insulin, it's just that nobody, I have adult clinic, peds clinic, nobody's using it. There's not enough, it's not effective enough. But insulin helps the body use the glucose that it needs for fuel, and it also helps store glucose for later. And when you don't make your own insulin, you have to think about 2 things. You need a certain amount of insulin just for your baseline life, living, not eating. It's sleeping, no matter what you're doing, your heart's beating, your lungs are working, your brain's working, you need insulin in your system to be alive. So that's called basal needs. And then there's mealtime insulin, which is to match the food, the carbohydrate and the glucose that's entering the bloodstream. So we're going to look at some insulins that are available these days. Previously, if you go back a decade or more, you're going to see that everyone used regular and/or NPH. Regular, the problem was its peak action was in 2 to 4 hours, and in fact, blood sugar peaks in about 1 to 2 hours after a meal. It didn't match. So people would have high blood sugar after the meal, the insulin would finally kick in, and then unfortunately it lasted way too long. So people would get low blood sugar way after the meal, and then they'd have to eat extra snacks to prevent the lows. They gained weight. It just didn't work. So 3 companies are now making these rapid-acting insulins: Lispro, Aspart, Apidra. They also have Humalog, Novolog, Glulisine as their second names because they make us all memorize 2 names for every drug. And they work really quickly. You take them, you eat. Don't take them and then go to the restaurant. You'll be low before you get there. They work right away. They peak in 60 to 90 minutes. They last 3 to 5 hours. They're done when the food's done. It's a really nice match. And NPH can be used as an overnight insulin, but now they also have glargine and detamir. And they're more predictable because they don't really have a peak action. They're pretty flat. They last 24 hours. They're just for your baseline needs. This slide shows the little blue line at the top. This is the hours after the meal down here. So if you eat a meal, the highest blood sugar is 1 to 2 hours after the meal. The red line is the regular insulin. You can see it just doesn't get there in time. The yellow line is a rapid-acting insulin, in this case Humalog, which is also called Lispro. Its profile matches the meal much better. It's much safer. We pretty much change everybody to that when they come here. Although people come all the time from outer-lying communities far away, and they're still taking regular and NPH, 2 shots a day. Not everybody is up on diabetes management. So premixed insulins are available where you're mixing NPH with a short-acting insulin in the same bottle, in the same dispenser. And it's 70-30 or 75-25 depending on the brand, but basically it's 70% of the longer acting, the NPH, and 30% of the shorter acting insulin. And that's fine to use these kinds of insulin with type 2 diabetes. It's totally inadequate with type 1 diabetes to use blended insulins. You can't fine-tune things enough. So conventional therapy, this 2-shot regimen idea, was in the past regular and NPH injected before breakfast. The purple line is the regular insulin's action. So if this shot happened at 7 a.m., it would last quite a long time. And then the other shot would be your dinner. So the pink line, or purple, whatever it's showing up as, would cover breakfast and then dinner. But at the same time, in the same syringe, you're injecting NPH, which has a much slower action, and that would be covering your lunch. And that would be getting you through the night. The big downfall is it always wore off before you woke up, and you woke up with a high blood sugar. Just didn't cover things right. And you don't need very much insulin from midnight to 2 o'clock, and that's when it peaked. So people would get low in the middle of the night. And the other problem with these kind of combinations is that the regular insulin lasts a long time, so that by the time the NPH is kicking in, you've got 2 kinds of insulin in your system, both being strong. And that occurs before you even eat lunch. So people would be passing out or being low before the meal. So that could be rectified in a couple ways. First, get rid of the regular insulin. It's almost, I just feel very strongly, it's almost never a good choice. The Humalog, the Lispro, the Aspart, these short, rapid-acting insulins, they match the food better, safer. And there's less crossover of action because it's wearing off before the NPH is getting strong. So that's a benefit. Don't take your overnight insulin with dinner. Take it at bedtime because it's going to peak in the dawn hours. And I don't know if you've heard the term dawn phenomenon. That's when your hormones start to rise. Your hormones go up, your blood sugar goes up. So your blood sugar starts to rise before you wake up. If you take your NPH at bedtime, it's going to cover that better. There's still a problem here. If you take NPH and you think it's going to cover your lunch, then you better eat on time. And you always have to eat the same amount of carbohydrate. You can't say, I only want a salad today, or I'm on the bus, or I have a meeting, because your insulin's going to work strong no matter what you eat. You better have food in there to match it. And so people get into trouble by taking that insulin in the morning and then not eating on time. So you can rectify that too by getting a long-acting basal insulin so that you eat whenever you want to eat. There's no surprise insulin starting to work hard. You just put in the rapid insulin at the mealtime. So if you eat lunch at 11, 12, 1, or 2, that's when you give your shot. It's not covered by something you gave in the morning. It's covered when you want to eat. So we're pretty much using this therapy for everybody with type 1 diabetes. There's differences with type 2. Now, interesting is there's a new medication for type 1 called Simlin. And the beta cells of the pancreas, it turns out, make another thing other than insulin. They also make something called amylin. And it's understood now what amylin is important for. Keep in mind, if you have type 1 diabetes, you've lost the function of your beta cell. So you don't make insulin, but you also lost the function of the amylin production. And now there's a medication that you can take to replace that. It's called Simlin. And it's injectable because it is a type of a protein polypeptide. It can't be mixed with the insulin. So unfortunately, if people want to take it, they're taking insulin in one shot, Simlin in another shot before each meal or significant snack, and that's the downfall, is a lot of people are not willing to do that, understandably. I hope someday they can manage to get them mixed. But what it's supposed to do is amylin delays gastric emptying, your stomach emptying. When you have diabetes and you're not making amylin anymore, your stomach empties faster, which means the glucose enters more all at once and your blood sugar shoots up. If you can get it delayed somewhat, your body can tolerate it and batch it away a little at a time. So if you stay full longer, you don't tend to snack as much, you are more satiated, and people lose weight. They do really well losing weight on this medication. And the other thing that amylin does is it suppresses a hormone called glucagon. And glucagon raises your blood sugar. So if we can suppress it, we can help postprandial blood sugar stay down. Now, in terms of delivering insulin, there are many options. Everyone's pretty familiar with the syringes and the vials. That's just fine. But there are some people that don't want to walk around drawing insulin up in the middle of a restaurant. They're self-conscious. Some people don't care at all. I have my teenagers that leave the syringe in while the waitress is taking their order, just for the shock value, right? But a lot of people try to play it down a little bit. So they have something called insulin pens. It's no bigger than this. This is my pointer, but this is the size of an insulin pen. And it just looks like a pen, so you can give a shot with that. There's also, for visually impaired, these big dial systems so that you can see the numbers and the insulin's inside here. There are people that use this blood sugar monitor that also holds insulin syringe and insulin. So there's the insulin pump. I have slides that'll show a little bit more on all of these. The pens are filled with 300 units. They're disposable. You can dial them up. Pediatrics, we have half-unit ones, but the adults generally don't need half units. They have almost every type of insulin available in a pen. The insulin pump, I would say we probably have close to 250 kids in the peds clinic on insulin pumps as young as 1 year old. We have lots of adults in our clinic on the pump. The interesting thing about the pump is it does away with the long-acting insulin. It's only one kind of insulin in this device. It's the rapid-acting insulin. And instead of the basal, long 24-hour acting insulin, this just comes out drip by drip by drip, continuously to provide the long-acting coverage. The downfall is if there's interruption to delivery, you have no insulin right away. You don't have any time ahead of you. It's not coming out, you have none on reserve. You could get ketones faster. But it's connected through this tubing, and then there's a set. These are what the needles look like. They can be short if you're really thin, longer if you're not. And you can disconnect here to take a shower, or we have teens that are on wrestling matches, they disconnect, or there are times you just don't want to be connected to something, you can disconnect for an hour or 2 hours. So benefits to pump therapy, it's certainly convenient to have that right with you. You just reach down and push a button and tell it how much to give you. You do have improved blood glucose control. There's less risk of low blood sugar because there's no big dose of insulin in there that's going to be acting for a long time that you can't take back. In fact, if you eat meals that digest very slowly, you can even have that insulin come out slower to match the slow digesting meal. With a syringe, you inject it, all the units are in at once. With this, you can say, I want 4 units evenly over the next 90 minutes, and it'll break it up into even increments so you can get better control. If you get called out to play basketball, you can turn it down. So you can just turn down what's happening right then and there, basal reduction rates. And you can even have various profiles. For active days, you generally need less insulin, so you can switch between profile A, profile B, that can be preset. And the nice thing is they do the math for you. You just say, my blood sugar is 280, I'm going to eat 95 grams of carb, and it says, I think you need this much insulin. Well, the physicians program that to say, give this person 1 unit for every so many carbs and 1 unit for this kind of blood sugar level. But the pump will do the math. Well, that's nice. Considerations is, it's not less work. The pump doesn't have a brain. It's not going to do it unless you tell it what to do. And you have to keep checking your blood sugar. They cost $6,000. Luckily, insurance will cover them, but they're not going to cover them if you're not a good candidate. Now, you're always connected to a device, and that's probably the drawback for people that don't want to have that on. And lots of training, lots of support. You have to keep records. You have to check your blood sugar. If you stop checking your blood sugar, you don't know if your pump's not working until you start feeling sick. Hopefully it's beeping, but there is an increased risk of diabetic ketoacidosis because there's no long-acting insulin on board. Now they have continuous glucose monitors with a similar set that fits into the subcutaneous tissue, measuring your blood sugar. Because the blood sugar monitors that we use on our fingertips give you a point in time. This is what your blood sugar is right now. If you check 4 or 6 times a day, it's what it was those 4 or 6 times a day, but it doesn't show anything about what's in between. And these monitors measure every 5 minutes and record that data, and you can put it onto a computer and get a printout, and that might help you to figure out where your insulin needs to be adjusted or how your pump needs to be adjusted to cover that discrepancy in blood sugar, okay? They started out pretty big. This is one of the first ones that was out, and that's pretty sizable. And if you're wearing a pump on the other side of the belt, you're feeling like you got a lot of hardware on. They got smaller. So this is the size of the Dexcom. It's very small. It has a receiver that shows the up and down of the blood sugar. And then when you print it out on your computer, it's going to give you something like this. The red points are the blood sugars checked on a monitor with your finger. The blue line is the blood sugar printout from this device. And what you can see is the person checked 4 times, really nothing horribly alarming. But what they didn't know is every night or early in the morning, 2, 4 a.m., they were getting low and sleeping through it, which can be quite dangerous. And often high after this meal, and that was never shown until they had a continuous monitor on. So these things are nice. They're not covered by insurance yet. They're very expensive. I'm sure they'll be covered in the future. And now they put those 2 technologies together, so they have an insulin pump that has its own blood sugar monitor reading into the same device, so that on your pump you're delivering insulin with these buttons, but you have a register here that shows what your blood sugar's been doing, and it has an arrow showing if you've been trending down or up, so you can prevent the lows and highs if you know which way you're going. So it's really a nice tool. But certainly will be a better tool when it happens without us pushing the button. So if the blood sugar starts to rise and the pump can release insulin and stop releasing when the blood sugar is going down, that's the ultimate closed loop system that we're going to see in the future. So as for type 2, we're going to switch gears here. Type 2, many people can control it by weight control and exercise. There are those who do everything right and still will have high blood sugar. So the first step is to do this foundation work and see if losing a little bit of weight and exercising regularly can control the blood sugar. Having said that, if it doesn't control the blood sugar, we're going to look at pills or insulin or combinations of that. The different pills, there's many more out there, but these are the main classes. And for example, sulfonylureas, common ones are glyburide, glipizide, Amaryl, but there's many, many more. If it's in green over here, these are the 3 types of medications that increase the production of insulin by your own pancreas. They tell your pancreas to work harder. And a lot of times these medications will work early on in the disease process, but after 10 years of making your pancreas do turbo work, the pancreas gets tired, and then it's not putting out as much insulin, and you see that that person might need to take insulin. So it's not uncommon for these to work, but eventually fail. Not for everybody, I don't mean to be negative, but if someone's on insulin, it doesn't mean they didn't try, it means they needed it. And then there's metformin, that decreases the glucose that's stored in the liver. So when you eat breakfast, lunch, and dinner, you have glucose. Some of that meal is stored in your liver as glucose, so when you sleep, it comes back out. And it's providing you glucose until you get to eat again. That storage comes from your liver. Byetta is an injectable new medication for type 2s. It's almost the same thing as what I was telling you about Simlin in terms of the type 1s. This is used for people who are already taking metformin or a sulfonylurea drug and they need something else to help. It is injectable. It makes the insulin work so much better in the person's body. And the nice thing is the insulin that's produced by the pancreas with this medication is only in response to when the blood sugar is rising. Whereas the sulfonylureas just turn your pancreas on for the next 12 or 24 hours. This medication only turns it on when you need it on. So it's a nice thing. It reduces the risk of low blood sugar. It also reduces glucagon levels. So that keeps the extra sugar in your liver where it needs to be. And it slows the stomach emptying, so that tapers the blood sugar level after a meal, and it makes you feel full longer so you lose weight. People do wonderfully on it if they get past the barrier of the injection. Also new on the market are these medications called gliptins, and Januvia and Galvus are the two out right now. They enhance your insulin production also, but only in the presence of glucose after a meal. So this is similar to the one I just talked about, Byetta. This is a pill, so there's the difference. It's a pill. It also has the benefit of decreasing glucagon, keeping the glucose in your liver where it should be. Let's compare the two since they're similar. Byetta, injectable. Januvia, Galvus, pills. So that's a benefit. The only problem is they both do the right things. They suppress the glucagon, the liver release of glucose. They increase your insulin when you need it after a meal. But there's no weight loss with the pills. So unfortunately, you're not going to get everything with just the pills. If you really are looking for the weight loss, it's going to come here with the Byetta. So blood glucose monitors are a big part of achieving glucose control, because if you don't know what your sugar is, you can't fix it. And you can use your fingertips, and a lot of them are promoting using your arm. I will tell you, though, it's not as accurate on your arm as your fingertips, which might be okay for type 2, but if you're basing an insulin dose on it with type 1, you want to be accurate. So the thought is the main blood travels in the deep vessels of your arms, and the surface isn't quite as perfused as the fingertips. So if you felt low and you had type 1 diabetes and your blood sugar was dropping, your fingertips might tell you you are low, you're 65, but on your arm it might still say you're 80. They think it's about a 20-minute delay. So if you think you're low or you think you're rising and you're going to take a dose, base it on fingertips is what they're saying. Targets, normal sugar before meals is less than 100. We're hoping for a goal of 90 to 130. Post-meal, normal, non-diabetic is less than 140 at the highest point. It's not abnormal for someone to wake up in the 70s if they don't have diabetes, so they might go from 70 to 140 after a meal, a 70-point rise and fall. That's very normal. We're hoping to keep post-meals most of the time under 180, and our targets are different depending if you're type 1 or type 2. We would love everybody to achieve that, but if we're giving insulin to a child who's at school who might get low, we might not aim them as low as somebody who's not on medications, where we could really strive to get them down there without causing them to be low. Bedtime, you want a safety net for someone on medication, so 100 to 150 is a target. Providers and physicians can help choose the blood glucose targets individually for people based on their medications and complications and health. But the monitoring frequency for type 1s, at least 4 times a day, but the more the better, 6 or 8. I see pregnant women checking 12 times a day. They want that baby to be healthy. Type 2s depends on how well controlled you are. If the hemoglobin A1C is normal, 5 or 6, and every time you check it's just fine, just keep in touch with those numbers by a few a week would be okay. If somebody's not okay and they're trying to change their medications and look at what that's doing, then get back to the 4-time-a-day checks, even if you have type 2, until that you see things are working out. And then gestationals at least 4 times a day as well. Vary the test time. So if you're only testing twice a day, don't always test before breakfast and before dinner. Those are the lowest times of the day. Check after breakfast and after dinner, and then you might be surprised at where you're going. You want to see those things. So you might check twice a day with type 2, but write them in a logbook in the right spot, so when you go every 3 months to the doctor, you've got several before breakfast, several after breakfast, several before lunch, several after lunch. Bring them all in so at least there's a spattering throughout the day and they can pinpoint where you need help. Okay, so type 1s and type 2s both need the values to show their provider, or they can't help you adjust your medication. And bringing your meter in doesn't work real well because nobody can go through the meter that fast and make sense of it all. It needs to be in a pattern written down. Keep the logs. Don't look at them negatively. All numbers are good numbers because they tell you data, and you can react to that data and take care of the diabetes. Children see the look on the parent's face when the blood sugar is 400, and children feel guilty and they feel bad, and so what do? They start writing lower numbers down. So their book's full of perfect numbers. They come in, we get their hemoglobin A1C, and it's 14. Those are not blood sugars in the 100s, those are blood sugars in the 400s. But if parents aren't looking at the values and the memory on these things, they're not going to know. So children need a lot of support, no matter how smart they are. They're not independent in this. They need a lot of support. So looking for patterns, looking for problem-solving ways, and parents should definitely learn how to do this technology. You can't have a kid on a pump with a continuous monitor if the parent's VCR is flashing 12 o'clock, because they haven't figured out how to change the time on the VCR. We can't have our kids more techno-savvy than we are. If they're on these devices, we need to know how to get in there and be responsible for them. Hypoglycemia is defined as less than 70, but some people might want to set that target as less than 100. If you have a frail person in their 80s, you don't want them falling over and breaking a hip, so let's not aim them as low. We don't want to cause them to be low. Children, less than 6 years old, low blood sugar can affect memory and development. We don't want to affect their intelligence, so we want to think about people individually. But if you are low, check to make sure you're low. And if you are low, 15 grams of carbohydrate is often enough to get you back up. But you need to check again to make sure that it did. And the carbohydrate used should be something that's absorbed quickly, nothing that has fat in it, because fat delays digestion. So you don't treat lows with Snickers bars, with chocolate, with peanut butter cookies. Anything with fat is going to digest very slowly. You want something that's in your blood in 10 to 15 minutes, like juice, fruit, pure sugar candies like Skittles or Starburst or Lifesavers are fine, but not chocolate. And then also, some people treat the low, and then I've seen parents give insulin for that. No, that's extra. You don't cover that with insulin. That's to bring you back to normal. And I've also seen people think, well, yeah, I'm low, but I'm about to eat dinner. And the plate of food is there, but when does that digest? The peak is in 1 to 2 hours. So if your blood sugar is 60, you obviously have too much insulin in your system or too much medication, and you can't wait an hour or two to digest something. So you start your meal with the juice, get stabilized, and then eat. Alcohol is interesting because a lot of people think alcohol raises your blood sugar, and in fact, you don't turn alcohol into glucose, you turn it into a fat. It's converted to a fat. It raises your triglycerides, if anything. There's a lot of calories. It can raise your weight. If it's a mixed drink like a margarita or daiquiri or Kahlua, sure, there's sugar. Then the sugar can raise your sugar. But the alcohol like bourbon and gin and vodka and whiskey, there's no carbs. Red wine, white wine, no carbs. They don't raise your blood sugar. The wine is converted to alcohol. You want to limit the alcohol, of course. But the big risk is that, let me show you on this slide. Alcohol is processed by your liver. Your liver, remember I said, is the organ that releases glucose when you're not eating. So if you are 4 hours past your last meal, you're burning glucose from your liver, correct? Where is alcohol broken down? In the liver. So what happens is the alcohol shows up in the liver, and the liver now starts to detoxify the alcohol and stops letting out the glucose like it's supposed to do. In the meantime, your insulin that you took, or your glyburide that you took, continues to push you down, but you cut off the source. You cut off the glucose from the liver. And people can pass out, people can die from this, from low blood sugars, because you are counting on the glucose from your liver. If you're interfering with alcohol, you're not going to get that sugar. So the bottom line is you don't drink on an empty stomach. If you're going to have the wine, have it with the pasta. If you're going to have the beer, have the burrito. If you're going to be at a cocktail party drinking before dinner, find some crackers or fruit. You can't drink on an empty stomach with type 1 diabetes, anyone who's taking insulin, or if you're on pills that raise your insulin production endogenously. So the more you drink, the more risky it is, because drinks can take 1 to 2 hours per drink in your liver. So 4 ounces of wine is 1 drink, or a shot glass of hard liquor, or a 12-ounce beer. And I do know one young man, college guy, who had 4 or 5 beers in the evening with his friends. College guys do that. That is not unusual. And he died because he had type 1 diabetes and went to sleep and got low but never woke up for that low. He cut off his liver's production of glucose and his insulin kept going. And that was that. So it can be very serious. You want to be aware of that risk. We're going to talk a little bit about exercise. For type 1, it offers all the same benefits as the general population, but it adds another variable which makes it harder to figure out your insulin. Because if you're exercising, you need less insulin. So we work a lot with people on planning their activity and adjusting their insulin and their carbohydrate intake to handle it. For type 2, it does everything you want it to do. It decreases insulin resistance, it increases the glucose burned by the muscle, helps with weight loss, helps lower the lipids, helps raise the HDL, which is the good cholesterol. It improves the heart strength, it lowers blood pressure, reduces stress. So it is a treatment for type 2 diabetes and should be thought of as such. We want to look for something on a daily basis. 30 minutes a day would be ideal. That's what the Surgeon General recommends. Others recommend an hour a day. But it is known it doesn't have to be all at once. For the benefits for type 2, it can be accumulated throughout the day. But you want to include, the impact, light impact aerobics along with the resistance exercise. And if you can't start with 30 minutes, start with 5 minutes every day. Then a week later, do 10 minutes. Just work up towards it. But if you have eye damage, you're not going to be lifting heavy weights and exerting pressure to the insides of your eyes, because that could damage those vessels further. So something like swimming or cycling, walking would be fine. If you have nerve damage in your feet, you're not going to pound the Stairmaster. You might set your feet wrong, and you might damage little bones in your feet by doing that. You're not going to want to jump rope or go jogging. If you have low sensation in your feet, do something more like cycling, rowing, chair exercises, swimming. If you have a neuropathy called cardiac autonomic neuropathy, that's something your doctor would have to figure out if you have or not. But the risk is if you have any forms of diabetes complications, if one of those things is the nerve to your heart, you could have sudden death from overexertion. So this is something, if you have any question, ask your doctor. There's no way I can tell you right now if you're at risk or not. If you have peripheral vascular disease, your legs hurt, you're having problems with circulation in your legs, the armchair aerobics where you're sitting down and doing things, or doing a little bit at a time throughout the day might be more comfortable, swimming, things like that. The community might have pools for handicapped available. Usually there's something all of us can do, and look in the community and see, is there an aerobics class you can take, or do you want to buy an aerobics video? Do you want to get any exercise machinery? I know you've had dietitians here, and I'm going to talk just in terms of the focus on diabetes. But I just want my point to be that if you have diabetes, you have the same human system that somebody who doesn't have diabetes has, and you need all the same food groups for those vitamins, minerals, and so forth. It's not like because carbohydrate raises your blood sugar that you should nix the carbohydrate. The number one cause of death with diabetes is heart disease. We're not going to take the carbs out and load up on the steaks, cheese, and eggs. It just doesn't make sense. We want a balanced, healthy diet. Low-carb diets don't give enough fiber, and we know fiber is beneficial for reducing risks of heart disease and cancer. Animal products are the only things that give you cholesterol because cholesterol is made by your liver. So that means plant foods have no cholesterol because they have no livers to produce it. And animal products have the bad kind of fat, saturated fat. So it's fine to have animal foods in your diet. We just don't want to say if you have diabetes, you need more. You don't. Carbohydrates are a part of a healthy diet. They're going to be represented in many different foods. In general, it's the same building blocks, but different assemblies that call the group carbohydrate. Glucose is a single sugar molecule. Fructose is a single sugar molecule. Lactose is two sugars connected together, as is sugar. Starch is just lots of sugars in a row, glucose. They branch off in different directions depending on if it's potato or corn or bread or pasta, but the building blocks are all glucose. Fiber is also glucose, but it has a bond we can't digest, so it doesn't turn to glucose. The fiber is not digested. But basically, whatever carbohydrate you eat, turning to glucose, goes into the bloodstream, pancreas releases insulin, or you take insulin, and then the muscle uses the glucose. What you don't need at that time is stored in the liver. So we need to manage that carbohydrate as part of managing diabetes. One of the ways we do that is through carbohydrate counting, so that we can eat the right amounts of carbohydrate throughout the day and match the medications to that. So in the past, someone with diabetes might be told, at breakfast, take 4 units. But if your blood sugar's a little high, take 5. If it's really high, take 6. But they never talked about, well, what are you eating? And you need to talk about that. Because if you look at this meal, the bagel, the banana, the juice is 120 grams of carbohydrate. And the very next day, equal amount of food, but this doesn't have any carbohydrate. Eggs have no carbs, sausage have none, cheese, butter, coffee, none. The only thing here that has carbohydrate is toast. So on one day you eat 120 grams of carbohydrate, the next day you eat 15. 4 units doesn't work for both days. You'll never get blood sugar control if you don't consider the carbohydrate. So we count the carbs. We can use food labels, food pyramid. The Diabetes Association puts out exchange lists. There's reference books you can buy at any bookstore, cookbooks that give recipes with the carb counts. Fast food, if you go there, they don't pass them out. We have a bazillion grams of fat, come on in, but that information's available if you ask for it. You go online. If you're looking at labels, whether it's starch or sugar, it's going to turn to glucose, right? So some people are just looking at the sugars. That's not going to give you the information you need. You need to look at the total carbohydrates. Sugars on a label could mean it has milk in it because lactose is a sugar. It could mean it has fruit in it because fructose is a sugar. And chemists separate it by the number of molecules linked together for this label, not whether it's white sugar or fruit sugar. So look at the total to get your information. In fact, they've done studies that show people with diabetes can include sugar in the context of a healthy diet in moderation. They separated groups of people and said everybody in the room gets 75 grams of carb. You half get 60 from rice and 15 from the cookie. You guys just get the rice. But you all got the same turkey and whatever else. The carbs were the same, the rest of the diet, the plan was the same, the blood sugars did the same thing. If you eat pure sugar by itself, just mixed in water like a soda, your blood sugar is going to go through the roof. But in the context of something mixed and in moderation, it should be fine. So fiber doesn't digest. So if you're having something that's very high in fiber, you can subtract the fiber from the total carbohydrates. If you inject insulin, that's when it becomes important, because you wouldn't want to have 2 servings of this, 9 grams of carbohydrate per serving. 2 servings would be 18 grams of fiber, from the carbohydrate. Someone with insulin requirements doesn't want to give insulin for that fiber because it's not going to digest. So people taking insulin are told to subtract the fiber from the total if it's a significant amount. More than 5 grams is what they're considering, 5 or more. Food pyramid, I put this in here just so you can check it out on the computer, www.mypyramid.gov. You can track your own age and gender, and it will tell you how many servings a day your actual body would require for balanced nutrition, so it's age adjustable. The exchange lists that are put out by the Diabetes Association are similar for weight control kinds of lists, and what they do is they group foods together, so all the starches are counted as 15 grams of carbohydrate per portion, all the fruits, the milks, the vegetables are only 5. Meats, proteins, and fats don't have any carbohydrate. So the way we use that is we teach people to memorize the basics that they eat over and over, and they can look things up anytime they want. But this would be an example of what a page would look like. A third of a cup of rice has 15 grams of carb. You can eat a whole cup, but that would be 45 grams of carb. So you just tally up how much you're eating. These are not portion sizes meant for you to eat at one meal. These are ways to count carbohydrate. Fruits, it's generally a small fruit the size of a tennis ball, or about a cup of melon or berries is going to get you in the ballpark of 15 grams of carb. If you have type 2, being in the ballpark's fine. If you have type 1 and you're matching your insulin exactly, it's a 4-ounce apple, a 6.5-ounce orange, it's 3 ounces of grapes or cherries. They weigh their food until they get really good at guessing it. Milk is 12 to 15 grams of carb per cup. And then things like asparagus, beets, broccoli are very low. A half a cup is only 5 grams. Type 2 diabetes, you generally don't count it. Type 1, you count everything to get your dose right. So here's what we teach people how to do. For example, here's one menu. Cup of pasta. They need to go through and figure out which foods have carbs and how much it has. And in this case, it was 45 grams of carb from the pasta, 5 from the sauce, none from the meat, 5 from the beans. We don't really count salad. So this person ended up eating 70 grams. If they had type 1 diabetes, they would have a ratio that they would be working with that the doctor would have told them. Take 1 unit for every 10 grams or 1 unit for every 15 grams. Now, if you're not on those kinds of ratios, you can't ignore carbs altogether. If you have type 2 diabetes, you want to learn how to count them so you can space them out more evenly throughout the day so your blood sugar will be better controlled. You have insulin resistance, you can't skip breakfast and lunch and eat all your carbs in the evening because your body can't do that. So with type 2 diabetes, it's learning how to distribute them. Some people will be on set doses to this day, but those set doses, based on blood sugar, it's called sliding scale, those should assume a basic amount of carbohydrates eaten at that meal. If you're on ratios, your dose is going to be based on what you ate and what your blood sugar was. So if a person took a unit for every 15 grams of carbohydrate, 90 grams of carb is 6 units. If they're told to take a unit for every 50 points their blood sugar goes above a certain number, then this person in this case would take 2 units, and they'd have to calculate that their dose is 8 units. Obviously, not everybody's going to be able to do that kind of math. We have a lot of different literacy levels. That's not going to always work. Sometimes we're showing food models to get the ideas for portions. But this is the ultimate way to get your diabetes type 1 controlled. Now, how much carb do you need? It varies. It depends on your activity, your weight loss plan, what do you want to weigh, your age, and all kinds of things. But I put this in just to give you a rough something in writing that you could look at in terms of how much carbohydrate. But the minimum amount is 130 grams a day, and that would be for a sedentary, small, older person. That's the minimum. It's a dietary reference intake that's been calculated. For a lot of people that have literacy issues, or for people who don't need to be so exact because they have type 2 diabetes that's pretty well controlled, maybe they just need to set their plate up like this. This is called the plate model, where half the plate is vegetables, quarter of the plate is protein, lean, quarter of the plate is starch with a small fruit on the side. Or maybe the hand method is enough for some people. Starch the size of the fist, whether it's rice or potatoes or pasta. Meat the size of the palm, same thickness. And then vegetables unlimited, salad unlimited. Limit fats to no more than the size of your thumb. So for people trying to control weight or trying to get a grasp of their diabetes, for a lot of people this is enough for type 2. It's not great, not enough for type 1. When you do count sugar, a tablespoon is already 15 grams of carb. That's the same as 3 cups of popcorn. So obviously it's very concentrated. So you have to be aware that you can't just have no limits on its use. You have to be careful with diabetes. Artificial sweeteners that are on the market, there are many. I will tell you that saccharin's been around since 1870, although it is not technically FDA approved. By tests that they did, they kind of grandfathered it in because of how long it's been around. But aspartame is studied safe for pregnancy and toddlers, as are these other ones. I think most people like the taste of Splenda the best. They don't have any carbohydrates, these. But sugar alcohols are often deceptive at best. They say sugar-free candy bars, sugar-free cookies, and ice cream, and you look at the calories, you look at the fat, you look at the carbohydrate. It's no better than a Snickers bar. And what they do with sugar alcohol is they take a sugar and they add oxygen and hydrogen to it. And once you do that in a chemistry lab, you can call it sugar alcohol. And since you modified it, it's not sugar. So legally, you can say sugar-free. But they didn't take the sugar out, they modified it. It's very tricky. Don't be tricked. Don't look at the labels for the sugars, because it'll list this as 0. Look at the carbohydrate and it all shows up again. So be aware of that. It can also cause a lot of gastric upset gas because you don't digest it well, because they added the oxygen and hydrogen. It doesn't digest well. For people who are taking insulin for it, they usually only count half of it because they don't digest it real well. Now, I know people in here probably heard about the glycemic index tables in other lectures, but people with diabetes always ask me about that, so I threw it in. There are some good things about glycemic index. Lower glycemic index foods are often healthier, but not always. So I don't want people strictly just using those tables to pick and choose foods. The big downfall is that they used 50 grams of carbohydrate per food on an empty stomach and studied what it did. Once you mix it with the other foods at the meal, it's not going to do the same thing. So it makes no sense to just say what happens when you eat carrots or watermelon, because it's not going to be the same when you eat it with your sandwich and your other things. The problem also is 50 grams of carbohydrate widely varies. 50 grams of carbohydrate from honey is maybe 3 tablespoons. From rice, it's maybe a cup. From carrots, it's maybe 7 to 10 cups. So consequently, carrots show up on the high glycemic index table, and we have people that don't eat them because of that. But nobody eats 10 cups, and we don't eat them on an empty stomach. It's not going to do anything bad to you. So you have to look at the big picture here. We don't want to look at these tables and say, oh great, ice cream and pizza are better for me than watermelon and carrots. That's just what I want to hear. So people will use these and they'll misuse them. So I think the best thing to think about is the glycemic effect of food varies on several principles. One, liquids are going to raise your blood sugar faster. Juice is the same as soda, cup for cup, in its sugar content. Fatty things digest slower. That doesn't mean we want to add fat to everything if we're trying to lose weight, but it does digest slower, so you don't use fatty things to treat low blood sugar. Refined grains digest faster than whole grains, so this is something to consider. Use your wheat bread, your brown rice, your millet, your oats, because they will be better tolerated than white bread and white pasta and so forth. The fiber in beans works wonderfully, in legumes and split peas. Smaller particles, the way you cook it, all these things matter. It's not just a glycemic index table, so don't get stuck with just stopping and looking at those lists. Now, in terms of weight loss, they have shown that losing as little as 5 to 10% of your current weight is enough to jumpstart your insulin. So that might be what you strive for instead of what in the back of your head you think I should have weighed when I was 20. 5 to 10% is often enough to make your blood sugar control much better, and at a rate of up to 1 to 2 pounds a week. And it makes sense if fat has the most calories per gram, that's a good place to try to target things. Cutting down on fat, watching portions, but increasing activity to get things in balance. In 1 pound of body fat is 3,500 calories. So it takes time to lose. If you do get a deficit going of 500 calories less a day, you'll burn 500 out of storage every day, and it would take a week to burn off a pound of fat. So 500 calories might mean just get rid of that piece of pie or that big bakery muffin. Those are 500 calories. Leave the mayo off, leave the cheese off, 200 calories. Baked chips instead of fried chips, another 150 calories you saved. You don't have to skip meals to lose weight, just choose healthier things. Limit fats and oils, choose the leaner meats, take the skin off the poultry. Your dairy products should be non-fat or 1%. Don't fry things. Try to stay away from caloric beverages. Sodas and juices are bad for diabetes anyway. Stay away from fast food restaurants, if I may say so, as much as possible. A lot of people gain weight because they eat for stress reasons and not hunger. Keep the exercise going. But you can't go too low safely. So I usually think women should stay at least 1,000 to 1,200 calories during weight loss phases, and men at least 1,200 to 1,600. Depends on body size. But at this point, you should be taking a multivitamin. When you read labels, you can use those labels not only for carb counting, but also for looking at fat content. The term low fat is defined as 3 or less grams of fat. Look at every label. 3 grams of fat or less is low fat. Dairy products, processed meats, crackers, ice cream, you name it. 3 or less is a great thing. In terms of heart health, striving for an LDL under 100, if you have heart risk factors, they're now striving for less than 70, which is tight. Triglycerides under 150, the HDL is the good cholesterol, men over 40, women over 50. The higher the better, because the HDL cleans out your blood vessels. And ways to do this with diet tips would be solid fats and animal fats. That's what raises your LDL. Get rid of those. Keep the meat lean. Use the healthy oils, not the solid saturated fats. Fruits and vegetables, limit salt, exercise. All of these things can help the heart. A lot of times patients are given a number. Oh, keep your calories from fat less than 30%, which means absolutely nothing to anybody. And so we just try to give low-fat tips. But if you are someone who wants to know what number of grams of fat should you have, based on the calorie levels on the left, these numbers would be 25 to 35% of your total calories as fat. And that's the guideline by most health institutions. So somebody needing 2,000 calories a day should keep their fat no more than this. And again, you're not going to go home counting everything, but once you know that number, if you see something has 50 grams of fat per serving, you might leave it alone. So it's nice to have that feel for the numbers. For example, each teaspoon of fat or butter or oil is 5 grams of fat. 6 nuts has the same amount of fat as a teaspoon of butter. A cup of whole milk, 8. An ounce of cheese, 8. Lean meat, 3 ounces, 9. You get up to high-fat meat, you jump to 24 in just 3 ounces. Now, back again, if your goal was 50 to 70, 3 ounces of meat being 24, if it's high-fat, that starts to hit home. But jump to the bottom, and a double Whopper with cheese is 63 grams of fat for one sandwich. It's more than 1,000 calories. If you know your fat gram budget, those are the things hopefully you will not reach for, just knowing those numbers. But in general, there are fats that are healthy for your heart. All fats are the same for your hips. They have the same calories, whether it's olive oil or lard. So if it's a weight issue, all fats restrict. If it's a heart health issue, reach for the vegetable oils, because if they're liquid, they're not going to clog your arteries. The best ones are monounsaturated, olive oil, canola, peanut oil. The worst ones are saturated, hydrogenated, and trans fats. They come in animal sources. They come in solid sources such as margarine and shortening. They'll raise your LDL. The way that the hydrogenated fats work is that they start as a liquid, then they turn them into a solid. So unfortunately, on the can of Crisco or shortening, it can say 100% vegetable oil. It was, and then they solidified it. Once it's solid, it's bad. It can say 100% cholesterol free, and it is, because cholesterol is only in animal products. If it's solid, if it's saturated or hydrogenated or trans, what happens when you eat it is your liver processes it and kicks out the cholesterol. So you can eat shortening, which has no cholesterol, and the net effect is you make cholesterol in your body. So that's why you need to reduce those fats. Cholesterol and fat are two different things. By far, it's the dietary fat that's raising cholesterol levels, much more than the dietary cholesterol does. It's by far the fat, the fatty food, the junk food. But you can't ignore that there are a few foods that are really high in cholesterol. If you have diabetes or heart risk factors, they're recommending 200 milligrams of dietary cholesterol a day, and an egg is that, or shrimp, or squid. Those are high. But if you're eating liver, it's the highest, because cholesterol is made by the liver. If you eat the liver, you eat the warehouse. You're eating all that animal's cholesterol. So organ meats should generally be limited. Go ahead for the holidays. If you do liver pate every season, then do it. But you just want to make sure you're not doing 3 egg omelets for breakfast, shrimp louis for lunch, and liver and onions for dinner. You want to keep the picture in mind. Hypertension, as I said, 130/80 is the target. And you can lower blood pressure with weight loss, with exercise, with limiting alcohol, staying away from cigarettes, and keeping the sodium content down. And I put the number on here in case you're a label reader, because if your budget's 2,300 milligrams of sodium a day and a can of soup is 2,000, you realize which things are really high. So to cut down on salt, basically the salt shaker should go. A teaspoon is 2,300 milligrams and 1 teaspoon of salt. Stay away from the packaged cured meats, pickled products. It's instant. You just have to add water and wait 5 minutes and lunch is ready. It's high sodium. So anything that's instant, top ramen, rice-a-roni, herb, pilaf mixes and things like that. So season with anything but salt, really, herbs and spices. In terms of vitamins and minerals, boy, there's a market out there trying to sell to people with diabetes, that's for sure. You'll see all kinds of things that they want you to buy. But studies show that it's not going to improve your diabetes unless you have a deficiency in those nutrients. And most people have type 2 diabetes, remember. 90% of people with diabetes, it's type 2. Of those, 80% are overweight. They're not typically deficient in specific nutrients. So it's not generally going to help them to take those supplements. It might be costing money. It might not be harmful, but it might not do anything. Okay, so I left lots of time for questions. I did write a book. One day, 2 weeks before my first baby was due, Random House called me up and said, do you want to write a book? And I was like this big, and I thought, oh my God, it's a good opportunity, maybe bad timing. But in all, a year later, I had it done. So that's available at Amazon, at the campus bookstore. And I also put my email on there, and you're free to send me an email. That would be fine if you have a question. Just put diabetes question in the topic, because I get so many emails. That way I can kind of prioritize. It's not from Viagra. I don't have to delete it, that kind of thing. Okay, so let's open it up for questions. Well, so your physician is telling you 110 is the target. I can just tell you that your physician knows you better and all your medical history, but the guidelines by the American Diabetes Association are 130/80. So I'm sure individuals can vary based on their other medical histories, and maybe your physician has a tighter target for you. The weight gain of the country has pretty much been the blame, as is most often thought, that in general, we have the same genetics we had 50 or 60 years ago, but as a population, the weights have gone up a lot, and people have become more sedentary in different kinds of jobs. They're not as active, and people are living longer. So with longer lives, in the older ages, you're seeing more diabetes crop up too. So it's a combination of those things, but they think that the weight issue is the main thing. Type 2 diabetes, there's something called metabolic syndrome. I don't know if you've heard that term, but people that have more of an apple shape rather than a pear shape, so thicker through the waist than the hips, are the type of people that tend to have more insulin resistance. So that leads more to type 2 diabetes. That same physique tends to lead you to higher cholesterol as well. So not everybody that has type 2 diabetes is going to have high cholesterol or hypertension, but it's a constellation that often occurs together, and it's very common to see. So when we teach our diabetes class here, we have a diabetes teaching center that I teach at for adults that have type 2 diabetes. It's a 2-day class, and it's part of the curriculum is the heart health, the weight loss, and the hypertension management, because when you're polling the group, pretty much everybody has those things, or some of those things. I don't know if you heard his question, but it was about alcohol. Basically what alcohol does, there's 2 ways your liver makes sugar. One is stored sugar. It's glycogen, and when you release it, it's called glycogenolysis. It breaks down what's already in there. You can only store so much. When that's gone, you make new glucose, which is called gluconeogenesis. And that's why people can go several days without eating, is because you will continue to make new glucose as needed. You make it out of your muscle. And that's why people in starving nations are so thin, is they burn their body to produce glucose. That's why people with anorexia die of heart disease. They use their heart muscle at some point to make glucose. But when you drink alcohol, it interferes with gluconeogenesis, the production of new sugar. It does not interfere so much with glycogenolysis. So if you have a good store in there, you'll release it for a little while, but then you're out, and the glucose that's produced new is impaired. But I've had people say, could lower your blood sugar. So does that mean if I'm 300, I could have a shot of bourbon instead of a shot of insulin to lower my blood sugar? But no, it doesn't take sugar in the blood and remove it. It just prevents you from releasing more from the liver. It does both. You burn a combination of fat and muscle, but you don't turn fat to glucose. You turn fat to ketones. So the Atkins diet, which promotes a very low carb, high protein intake, those people will run low levels of ketones. You can run low levels of ketones by not eating enough carbs. In order to burn fat properly, there has to be carbs there together to make the carbon dioxide byproduct. So if you take away the carbs and you burn fat, you'll get some ketones. But people like that won't get ketoacidosis. That only happens when you take away insulin, because then you can't burn any carbs. That's when you get ketoacidosis. So when you have somebody who's not getting enough fuel, they're going to break into muscle and fat. But you don't turn fat to glucose. In the brain, the heart, the lungs, the vital organs, the preferred fuel is glucose. That is the way the body's supposed to do it, is burn glucose. You will burn both when you're losing weight. But you definitely tap into muscle, not just fat. It's not fat first. How does diabetes affect kidneys? Okay, so whenever the blood sugar goes too high in the body, one of the main things that causes complications is that the extra blood sugar can't be gotten rid of fast enough. Your kidneys try to get rid of the glucose, so you pee out the glucose. So if you go and you pee in a cup, they can dip it and say you have glucose in your urine. That tells them your blood sugar is over 180, because your kidneys start to drop the glucose at about 180. But how does it damage your kidneys? It takes years of high blood sugar, because when the blood sugar is high, the sugar molecules stick to the inside of the blood vessels. So think about a hose or think about the pipes in the bathroom, how that stuff starts to sludge up in there. That's kind of what happens in your body with glucose, is it starts to stick in there. And the vessels in your kidneys are as fine as a line with a pencil. They're very small. So they're not going to take a lot of that before they have problems. You're going to get damage to those vessels. Now, one thing that's interesting is if you have any damage to your blood vessels, they can test that on your kidneys by collecting the protein. Anybody with diabetes should have their kidneys checked once a year by collecting urine. They'll dip it, they'll check the protein amount. If you have an abnormal amount of protein in your urine, it indicates that you have some kidney damage. And there's a certain level where they consider it very serious. Once you have any damage to your kidneys, high protein diets accelerate the loss of kidney function, because your kidneys clear the protein waste products. And so if you're eating lots of protein and you have a damaged kidney, you lose your kidney function much faster. So people with any kind of kidney damage are put on low protein diets with diabetes. So the best thing I can say is if you have any kidney problems, the best bet is blood sugar control along with blood pressure control. And one of the medications used most frequently is something called an ACE inhibitor. It's a blood pressure medicine that specifically benefits the kidney. So you might want to talk to your doctor about that. It is a huge subject, the biochemistry and genetics of diabetes. You know, I tried to focus on things that people could do to help prevent complications and elucidate some of that information. But type 2 diabetes has a very strong genetic component, and specifically in certain ethnicities. And you can see if a parent has type 2 diabetes, it's so frequent that the child has it. With type 1 diabetes, that is not the case. If you have type 1 diabetes, your child has about a 3% chance of getting type 1 diabetes. It's low. Type 2, the Pima Indian population has the highest incidence. More than 50% of their entire population has type 2. So part of it is genetic. Now, type 2 diabetes is insulin resistance. It's that transportation of glucose from the bloodstream into the cells. And it might be a defect of how the insulin attaches to the surface of the cell. It might be intracellular defects, and they've mapped the genes for these sorts of defects, and there's not just one. And that's why some people are relatively easy to control, because they might have a minor defect, whereas other people, being thin, eating right, and their sugars are still high because they have multiple defects. And it is pretty complicated biochemistry that I probably can't do enough justice to in a short amount of time. No, high fructose corn syrup and fructose are not the same thing. So fructose is the natural sugar that occurs in fruit. It also occurs in some vegetables. It's a single sugar molecule. Now, the interesting thing about fructose as it occurs in food, the natural substance, is it doesn't raise your blood sugar as much as other sugars, Because when we absorb our foods that we digest, we absorb our carbohydrates as single sugars. There's glucose, there's fructose, there's galactose, there's different ones. But fructose can't be used as it is. So what happens to it is when you ingest it, it goes first to the liver, and the liver says, oh, why don't you just stay here? It turns it to glucose and it stores it for later. Or if the body needs it, it quickly converts it to glucose and lets it out. But it makes that first stop at the liver. So there is some benefit to the naturally occurring sugar and fructose. For example, if people go to a health food store and buy powdered fructose, and they have that in the house because they're trying to be healthy, it's not fructose corn syrup, it's powdered fructose instead of white sugar, and they bake with that, the blood sugars don't go up quite as much because it has to go to the liver first. But unfortunately, other studies show if you go too high on ingesting fructose, it can affect your lipid profile. So we're not promoting to do that. We just ask people about it because we don't want them to use it to treat low blood sugar. If they have it in the house and they think that's going to raise them when they're low, it won't. So anyway, high fructose corn syrup is a highly processed, I'm sure it was talked about in other lectures. There's a lot to be said about it. In terms of diabetes, tablespoon for tablespoon, the effect on the blood sugar is the same, whether it's white sugar, maple syrup, high fructose corn syrup, honey, all those things. They're all about 15 grams of carb per tablespoon, and a lot of people will tell you they don't think high fructose corn syrup is very, very healthy. In general, it's in high processed foods and to limit it. Agave nectar is different, honestly, if you haven't heard of that. Agave nectar is a sweetener that's from the agave cactus, and it turns out that it's mostly fructose, and that's why it doesn't raise your blood sugar as much as another kind of syrup. So these are real subtle points, but when you go to the Diabetes Association, there's the agave nectar booth where they're trying to give you a bottle so you can try it and tell all your patients about it. I tried it. I thought it tastes really good. I don't have diabetes myself, so I can't do a personal test on myself, but I've had people say good things about agave nectar. Anybody else? Okay, well, if you have any individual questions or if you're interested in a book, you can come on down. Otherwise, thanks for coming.